All right, Bismillahirrahmanirrahim. Thank you very much for being here this late. This is the last talk for the day, so I'm not going to take much of your time. So my topic for today is MINOCA and SCAD. So these are the unusual presentations of patients with ST elevation MI. You do timely angiography, and there's not much to blame that you can see. So these are, of course, patients who are ischemic, but many times you're unable to see the etiology and you don't know how to treat it. So the clinical presentation is classic. They come with the same symptoms. They have cardiac enzymes positive, ECG changes, segmental wall motion abnormality. And when you do an angiography, there is less than 50% blockage. So what to do? And you don't have any other diagnosis to blame in those cases. So what we are seeing in these cases is that in about 45% of these patients, the underlying etiology is still ischemia, but you're not able to see it unless you do an intravascular imaging, and you can see these small fissures which are there responsible for the plaque which was there that caused the symptoms of the patient. Remember that when you do an angiography, you're actually seeing about 5% of the total coronary tree. The microvasculature, which actually because of our lifestyle habits gets disease much earlier and much more extensive, is not visible to our naked eyes. So the potential mechanisms by coronaries that you're looking at as a plaque disruption as being number one. Vasospasm, especially in females, is number two, dissection. Many a times thromboembolic phenomena. You can see many a times these patients with just Takotsubo kind of physiology in which you don't have any coronary disease, but when you do an echo, there is a very classical shape of the myocardium, the whole, just like an octopus trap that you can see is called Takotsubo syndrome. And supply-demand mismatch, which might be because of many other etiologies, anemia per se, or that we see clinically in patients with a lot of comorbidities. When you're looking at the non-coronary causes, these are the patients who are coming with myocarditis, cardiomyopathy. These are the patients either with dilated cardiomyopathy or hypertrophic. These patients can present with MINOCA. Pulmonary embolism. Renal, we know that these patients many a times are unable to clear the troponin from their system, and that's why they might present with high troponin numbers and get a very common cardiology consult. Then sepsis is another one that we see. So when you're doing the differential diagnosis workup for these patients, the most important part is that don't lose focus on your cascade of workup. Clinical history is most important part. So when you're taking your exam, your examiner is going to give you a presentation. Don't lose focus on asking the right questions. Then following the echocardiography being segmental wall motion abnormality, looking at what can be the possible etiology for your MINOCA patients. The center point for MINOCA are actually two that unfortunately we don't do that much in our clinical practice because we don't have intravascular imaging. We don't do mostly pressure wires in our patients. We don't have cardiac CMR. But from exam point of view, since this is a course for our fellows, these are the important things that you know are needed for your diagnosis for these patients. So when you're doing an MRI for these patients, CMR gives you an idea that if there's a late gadolinium enhancement at the subendocardial region, most likely it's an ischemia, which you're not able to see in the coronaries because either you have are doing this angiography a little late and the clot has been dislodged because of anticoagulation, antiplatelet therapy that was given to the patient. If there is a CMR late gadolinium enhancement along the epicardial area, then those can be myocarditis. If you're seeing edema in the muscular tissue, but there is no real gadolinium enhancement, then if your segmental wall motion abnormality on the echo goes, then the diagnosis of Takotsubo by CMR is also confirmed. So CMR is the key imaging modality to be used in these patients when you're doing a workup of MINOCA. So there is a position paper which actually come up since 2017, And that also signifies that once you have reached that coronaries are clear, patient definitely had an MI, what to do next? You have to do either a intravascular imaging by IVUS or OCT, or pressure wire them. Or if, you can't see that there is a spasm which might be responsible for patient, then acetylcholine test needs to be done in the cath lab, which is going to induce the spasm, and you can actually document that. Otherwise, CMR is going to give you, by late gadolinium enhancement, whether this is a myocarditis or this is some sort of cardiomyopathy that needs further workup. So by etiology point of view, acute MI is one of the major ones. Then we see that myocarditis is the second one, and most of our patients, in spite of our limitations in our cardiac centers, we are not able to do CMR or so, and they become the last one being underdiagnosed, and we don't know their etiology. But these are patients who actually carry worse prognosis than your regular patient who don't have an MI. Of course, they have better prognosis than MI patients, but these are the patients that really need medical attention. By medications, giving dual antiplatelet and giving them beta blockers does not result in better outcomes. But giving them ACE, ARBs inhibition is definitely way to go, and statins also play a good role in these patients. My second part is the spontaneous coronary artery dissection, and by Yipsock classification, the type 1 is what we are seeing is normally a small filling defect that is seen. Mostly the female patients, 90% comprise with the presentation of this modality. Unfortunately, these don't have the classic atherosclerotic risk factors. So if you're not paying good attention to the risk factors, you'll see ST elevation in MI, you end up giving thrombolysis, and that's not a good thing, especially when they have ST elevations which are being shown. When you do an angiography, the classical finding is a smooth, narrow, long segment of the coronary. And that is the classical type 2 that we see. The type 3 is something that we get confused with atherosclerotic etiology. And type 4 also, once there is a total occlusion, is really hard for you to judge unless you do an intravascular imaging in these patients. The most important thing is that your etiology-wise, they can be a vasa vasorum, small rupture inside. It's called an inside-out theory or outside-in theory. And many a times what happens is that the plaque rupture, actually the intracoronary blood many a times enters, and that becomes the reason of a false lumen getting and compressing more and more on your true lumen. So OCT studies many times have been done in these patients, and they have many times confirmed that they have extracoronary disease as well. If you do their cerebral imaging, might find AV malformations. Sometimes as a flyby renal angiography, you can see the fibromuscular disease in their renal arteries as well. So fenestrated versus non-fenestrated depends on the vasa vasorum. Many a times there are a lot of vasa vasorum next to it. OCT is the test to do because of its accurate, very nice imaging that we get to see from this technique. These are the shadows which actually there's extravascular extravasation of the blood which is compressing on the true lumen, causing the stenosis, and you don't have any other way just by angiography to diagnose this. IVUS has a limitation because of low spatial resolution, and you can't really differentiate atherosclerosis versus false and true lumen. Very selected few cases you can do that. With OCT, many a times when you do a high pressure flush, that can worsen the, your dissection, and that becomes a complication. As in this case, you might find it a little difficult to see, but after OCT, actually, the whole artery shut down, and that becomes a problem. Classically, how the smooth, narrow coronaries in the LAD or RCA that you can see, this is the classic presentation. And you can differentiate the true lumen and false lumen around it, and if it's compressing, then it really becomes a big problem. So in management, this is my last slide, no thrombolysis because you need to pay attention to the clinical history, especially in pregnancy, peripartum period. These patients will present, mostly females. You should treat whether pregnant or non-pregnant the same way. I mean, just put a shield on the fetus and don't, give them this disadvantage of not giving them aggressive treatment with primary PCI in these patients if you can do it. If you know it's SCAD, then in those cases, it's advisable if they're stable to give them 30 days for them to be a little more able to ride it out, let the coronary false lumen resorb the blood, and then when you do an angiography a month later, that will be definitely much easier. Give them dual antiplatelet, beta blocker, ACE, ARBs, statin post-delivery is important. But whenever there is an unstable plaque, many a times you might have to use actually a scoring balloon to make it fenestrated, let it bleed out, let it decompress so that the true lumen can expand and you can do PCI. Because if you don't do that and you just put a stent, it's just going to milk that clot intramyocardial hematoma ahead, and those cases won't do well. So this is my last slide. Thank you very much for your attention. Thank you.
So we have a very informative session. Any question from the audience?
Kamran, just a quick question. Like patient, MINOCA patient, when you discharge them home, what kind of prescription you are going to write and for how long?
So these are the patients that you know that if they have atherosclerotic risk factors, treat them as if they're an ischemic patient, but you're not able to see. In reality, what our practice is, what we are seeing currently is that these patients don't get angiography in most centers of Pakistan in time. They get SK or some treatment in periphery, they come late. So you really don't know when they're presenting with high troponins, with segmental wall motion. Most of our cases are going to be ischemic heart disease, so dual antiplatelet for 1 year, give them high-dose statin, ACE, ARBs, beta blockers, just like a standard therapy that you give for any ischemic heart disease.
Thank you, Harun, for an excellent presentation. What would be the role of contrast echo in patients with MINOCA? Because you would have the myocardium either light up or become darkened. That is one. And the second thing is about the CMR. When you actually when you do a CMR, and if it is transmural infarction, or it will be different with a late gadolinium enhancement. And with cardiomyopathy, it would be diffuse kind of a mid-ventricular enhancement. So probably that's where you could differentiate between the two. But my feeling is that MINOCA would have a better diagnosis if you were to do a contrast echo, and probably strain imaging would, in the future, also be useful in this kind of a condition.
Very true. Very true. The contrast echo, when you're using, actually it enhances the lumen, the inside, the cavity of your LV. So segmental wall motion really gets better when you're using a contrast echo modality. But when you do a CMR, that is where actually your lead gadolinium is going to enhance the scarred area, because the dead myocardium is going to let that gadolinium go in between the myofibrils, and that dead area is going to be showing up much more clearly. So if it's an ischemia, mostly subendocardial, but if there is transmural infarct, the whole myocardial wall is going to be whitened out. And if there is a myocarditis or there is some other, so subepicardial area is the one that lights up. And you can see Takotsubo has a different, so CMR people, when they do it, they actually have already done an echo. They know how the segmental wall motion is. But when they see an edema and there's no gadolinium enhancement, and then you can see that how that wall motion makes this whole big jar at the end, apical area, then you can really have a differentiation. Amyloidosis, and also if you have HOCM, like especially apical HOCM, then that actually has an absolutely opposite look in a CMR. So CMR is a good modality when you're looking at someone post-MI or someone with low EF and you want to know the etiology, whether it's ischemic versus cardiomyopathy.
When you're using opsonin.
Opsonite, yes.
At that time, it lights up the
myocardium as well. But mostly, I mean, whenever you have suboptimal echo studies, that has been the class 1 indication of using an echo contrast.
Thank you, great talk. I guess, what do you think the role of intravascular imaging is in MINOCA? Because a lot of times vessels look normal, but you know, on IVUS or OCT, you may find some pathology. And a second part for SCAD is that my understanding was that the inside-out hypothesis for SCAD, the endothelium is, you know, if you touch it, it's going to dissect further. So just leave it alone. Is that what the current?
Absolutely, you're right. So basically, if there's a unstable plaque and it ruptures, it starts filling up the space between intima and media. So in those cases, you really don't want to push anything further. Most of the time, when you have a good clinical history, we try to shy away from any angiography or any primary PCI in patients, especially if the history is suggestive of SCAD. In those cases, you just go for conservative therapy, but there can be patients who actually are unstable, either arrhythmic, low BP, ongoing ischemia, STs are not going down, they're having severe chest pain. In those patients, you end up biting the bullet and you have to do something. So when you go inside and you see and you kind of like just doing a plain angiography, then you would want to improve the symptoms of the patient right away. So in that case, if you still believe that there is, if it's a type 1 in which you just see a very small nudge and you're not so sure, everything looks good, many a times that has become a justification for some cardiologists, even in America, that they end up just doing a PCI of a place that they believe would have caused an MI, and I think it's something which can become unstable later, so I thought that it's better to stent it. Most of the guidelines don't want you to do that. Or even in your exam, if it is like that, you see haziness, and you believe that there is something, intravascular imaging is that what helps you in that case, that it will show you the plaque rupture, it will show you where the nidus of the problem is, and that will help you decide whether you want to do a PCI in that case or not.
Okay, any quick comments from the panelists? If anyone want to say anything quickly.
Thank you very much, all of the presenters. It was excellent presentation by all of them. And a lot of diversity I came across. No doubt we cannot go against the guidelines. But there is one question which all of my senior experts and my colleagues are sitting here. Like somebody has a blocked LED, and you see it 24 hours have passed. And how can you say that? What is the rationale that if you open it, it's no good for him? Unless you do a viability scan or unless you do a viability study. So this is my question to all of you, and especially to Dr. Mikdad as well. I'm not challenging the guidelines, but just my own query.
One of the colleagues sitting in the back from Turkey, he was asking the same question. So,
yeah, this is a very common question asked, because especially in the Sehat card era, where it's not costing a penny to the patient and you think that you are doing benefit. When I first came to Pakistan, I still ping pong between the two countries, but that philosophy is so different. You can't explain it by, just saying it. But if you do PCIs, how many times have you done PCIs of totally occluded artery, asymptomatic person, no viability with the improvement of LV function? The answer is 0.
Oh, that's right, especially when you say no viability. But when you say asymptomatic is no, I don't think that carries any weight, unless you test for ischemia. If you test for ischemia and there is no viability, of course you will not do anything. That is very clear. But if, unless you test for viability, you cannot say that he is asymptomatic, because silent ischemia is there as well.
No, I will add on second thing.
ACC guidelines, AHA, SCI all say don't do it unless they are either symptomatic or they have large area of ischemia. These are the guidelines in
yes, I agree, but you have to check for the symptoms. You have to check for it with other gadgetry, rather than only by what he says.
Sir, I agree with you.
Can I make a comment, Dr. Mikdad? Even if a person does not have viability on a scan, a nuclear scan, or even on FDG PET also, there is a twilight zone which is still viable and is not being shown. And if you have an open artery, for example, in the Oates trial, the open artery hypothesis, because later on at because this is a progressive disease, It is not just going to affect the LAD, which is totally occluded, or it is not going to affect the circumflex later on or the right coronary. But if you have an open artery, you will be able to, I think, improve the ejection fraction a little bit and also have a conduit for future events which this patient might have.
I'll just answer by one simple sentence. If
strong
you look at OATS data, zero benefit. You know, go by data, randomized data. Don't argue with like my experience, my relative, young guy, and forget about these things. If somebody is having heart failure, we're not saying people who have symptoms, don't do it, do it. But just doing it for the sake, I did not show you one last stitch data. Look at stitch data. People who had viable myocardium did well irrespective of what you do. People who had no viability, you can put them in cabbage, you can put them whatever, makes no difference.
Last week I did
This is
an
this is what
echo.
we are saying.
Sir,
Viability has to be tested.
Sir, last week I did a patient's an echo. The aneurysm is size double the size of you can say resting heart, even RV and LV. And 2 years back, after interval MI, pre-discharge stent was implanted and just on short of breath. Always ask patient chest pain or
I think
short of breath.
there's a lot of controversy among this. In this fellows course, we want to give them a clear message. And the clear message is we have to follow the guidelines for now. And according to the guidelines, it says that it is a class 3. If you do it, if it's a occluded artery, if you do it after 3 days, it is a class 3 indication. You should not do it for the purpose of exam and for like whatever guidelines or data we have. Again, we say guidelines are guidelines. A lot of time you have to use your own judgment. There's a lot of, you said these, the health card and all those are things of our own financial motives, and we drive us. A lot of us, despite knowing this, will end up doing that. But again, for exam purpose and for fellows, I would say we should follow the guidelines at least for
Yes,
now.
Dr. Bashir, there is no argument in it.
But as I said,
That is
there's a lot of
agreed
controversy.
for that.
There's
Yeah.
a lot
Of course.
I
I think the
right.
confusion arose because all of us saw that picture of the proximal LAD and total occlusion on third day of MI with no collaterals. So obviously it appeared that this is a new thrombosis or a new occlusion, and you can't say that the entire myocardium is necrosed in that territory. Either patient go for viability studies, but he should be pursued further. But you can't just leave it because, he's asymptomatic at this stage.
Just one thing.
Definitely.
Guidelines say totally occluded artery. So it doesn't mention if the artery is being filled by collaterals. So if you have well-developed collaterals, I don't think then you should consider it a non-viable myocardium, and then you should try to fix it at the time without even doing viability study.
Yeah, there was no collaterals at all. Trust me, follow me, you will be safe in exam.
I guess when somebody cath after a day after MI, they've been lying there, asymptomatic word is a little, until they start moving around. The only issue becomes is if you leave it alone completely and becomes a CTO later on, it becomes more challenging to open and all that. So if it's a viable myocardium, I'll bring them back a week later. Maybe not do it right away. If they're asymptomatic, you'll also decrease the risk of no reflow. But yeah, the guidelines, OAT is basically not opening a vessel to a non-viable myocardium.
Agreed.
Okay, so I think...
So finally, one
Yeah.
comment on multi-vessel PCI in non-culprit vessel in setting of acute MI, FFR guided. The recently published FAME-3 trial have failed to show any superiority of FFR guided PCI over angiographic guided PCI in acute setting. This just published.
Yeah, I know. But one thing, I think one of the purpose for discussing this thing is that a lot of patients, at least I see, that has like severe triple vessel disease, calcified CTOs in multiple vessels, and they will come, let's see, inferior wall MI and right is occluded, and LAD, left circ, all those are also occluded. In this kind of patients, our practice, at least at my institute, is that we want to make sure that artery is open. We'll go ahead, balloon it, and wait for a few minutes. If the artery stays open, we don't put a stent in. will leave, wait for a few days, and then bring them back for surgery. I've seen a lot of patients now who has the stent, like multiple stents put in one vessel and all other vessels are not angioplasty-able, and patient is symptomatic and you can't even send for surgery. You can, but there will be a risk of bleeding and all those things. So we have to make sure if somebody has severe multivessel disease, we should try to open the artery with the balloon and not put a stent. If you waited for a few minutes, it keeps closing again and again, then you can probably consider putting a stent in. But otherwise, I personally would avoid putting a stent in that particular vessel.
That's fine. That's
okay. So I think thank you very much. Just a couple of quick comments. We're sorry that we got a little bit late today because of some technical issues, and a few of the speakers went a little bit more than usual. Pakistan Live has always stayed on time, and our actually nurses did better than today. They were on time and finished on time everything. Inshallah, from tomorrow, again, we will be staying on time. Tomorrow, we have excellent sessions all day. We have international live cases. It's going to start at 8 o'clock in the morning. At 7 o'clock, we have the learning sessions, excellent learning sessions. Those who have registered, that's fine. Those who haven't registered, they can still come and see if there is a space. We will register them on site at that time and let them get in. But again, excellent learning sessions. They will start exactly on time at 7 o'clock and 8 o'clock. We have a case with the Society of Cardiovascular Angiography and Intervention. We have a combined session. Ihtisham Mahmood and the SCAD president will be there. They will be showing a case as well. And then we have talks. It's a bifurcation, left main, and excellent discussions, which will basically, what you learned today will build on top of that. So thank you very much for everyone staying so late. I'm glad to see so many people sitting so late at this time. And all the speakers, all the panelists, I think all the talks were great. Excellent review. I myself learned a lot of things despite being basic things. So it's good for all of us. And I really appreciate everyone's efforts, and thank you very much.
Thank you.
Thank you.